with Dr. Goldhaber. We're lucky to have him in our first slot. Dr. Goldhaber is a professor of medicine at Harvard Medical School, an associate chief and clinical director in the Division of Cardiovascular Medicine at Brigham and Women's Hospital. He's the section head for vascular medicine and the director of the thrombosis research group at Brigham and Women's Hospital. And he helped to found the North American Thrombosis Forum. We're super fortunate to have him here this morning talking to us about current approaches in the management of venous thromboembolism. So good morning, Sam. Take it over.
Well, good morning and welcome, everyone. It's really a pleasure to speak again at this fantastic comprehensive course. This is a little bit about me, and here are my disclosures. What I'm trying to do over the next 50 minutes is pretty ambitious to cover 8 points related to venous thromboembolism: epidemiology, artificial intelligence, inflammation-linked conditions that trigger VTE, post-pulmonary embolism and post-phlebitic syndrome, DOACs, the optimal duration of anticoagulation, advanced management of high-risk pulmonary embolism, and prevention with a focus on managing obesity. Well, looking at the statistics, we as a nation were doing great. If we go back to 1980, in terms of a marked reduction in cardiovascular deaths, both among men, shown in blue, and in women. However, things started to change in 2010 for reasons we don't truly understand. And the cardiovascular death rate has particularly gone up these last 3 years, with men now having a much sharper rise in cardiovascular death than women. In terms of pulmonary embolism, we're doing great with a reduction in mortality in non-high-risk pulmonary embolism. But again, for reasons we don't entirely understand, high-risk pulmonary embolism mortality is increasing. These patients are almost always hospitalized, so you, as hospitalists, are going to be dealing with this challenging group. Now, does socioeconomic status play a role in pulmonary embolism? When we look at heart disease in general, over the past several years, we see a marked increase in the percent of heart disease deaths in Blacks, Hispanics, and Asians, but only a tiny increase in whites. And here are some examples of health equity barriers in pulmonary embolism. You probably have a pulmonary embolism response team, but these are often restricted to well-resourced centers. And there is probably some advanced pulmonary embolism therapy available to you, or that you can get by transferring a patient to a tertiary care facility. But reperfusion therapy is limited in socially and economically disadvantaged populations. Finally, another example, state-of-the-art anticoagulation with DOACs, which are expensive, is limited when the population is socially and economically disadvantaged. And I think that these factors contribute to our failure to reduce pulmonary embolism-related mortality, particularly high risk. Now, in terms of AI, this is going to make an important breakthrough because the inputs are chest CT, clinical data, and lab results. And then the neural networks identify repeating patterns of abnormalities. Natural language processing identifies risk factors, symptoms, and signs to generate clinical probabilities. And the outputs are any abnormality, yes or no, detection of pulmonary embolism, and even figuring out what segment of the pulmonary artery the pulmonary embolism is striking. Here's an example from the real world. These CT scans were read remotely. Radiologists, I had a night shift, 12 hours long. And this first CT scan was properly identified as positive for pulmonary embolism by the radiologist. AI checked it anyway, and sure enough, it lit up. But toward the end of the shift, another CT scan shown here has a pulmonary embolism, but the radiologist missed it. And I think we can certainly understand how that can happen in the real world with a long shift and working in a lonely place all night. However, AI, which double-checked the readings, did pick up this pulmonary embolism. Now, risk factors for VTE are focusing on inflammation. We also have certain laboratory tests of hypercoagulability, genetic, acquired, and genetic or acquired. And now we're paying more attention to the inflammation-linked conditions that can trigger PE or DVT, such as ulcerative colitis, Crohn's disease, rheumatoid arthritis, psoriasis, or an elevated LDL cholesterol level. LDL is a very inflammatory molecule, or an elevated lipoprotein little a. We are also recognizing the importance of diagnosing and treating obstructive sleep apnea, because nocturnal hypoxia is associated with an increase in VTE. In terms of the relationship between cancer and pulmonary embolism, pancreatic cancer has about 20% of its patients going on to develop usually large pulmonary embolism. And other major contributors to this relationship are GYN, especially ovarian cancer, biliary cancer, situations where the primary tumor can't be identified, gastroesophageal cancer, and urinary bladder cancer. One thing we're trying to do is to abandon silo thinking. In other words, yes, we have VTE, but it does not exist by itself. It is connected and overlapping with other common vascular illnesses such as myocardial infarction, stroke, and peripheral arterial disease. And treating the patient with pulmonary embolism is just the beginning of our mandate. We have to also be on the lookout for post-PE impairment, which is estimated to be 16% of the PE patients who are followed up for 2 years. And this can be associated with death and rehospitalization, as well as the development of chronic thromboembolic pulmonary hypertension and a decreased quality of life. Here we see a patient who had a pulmonary thromboendarterectomy to remove this huge amount of material from both lungs. And this operation can be curative for patients with chronic thromboembolic pulmonary hypertension. Now, post-phlebitic syndrome of the leg can be problematic both in the hospital and in the office. It's diagnosed clinically in patients with chronic venous insufficiency and a DVT that occurred 3 months or longer before the chronic venous insufficiency. And it's very common. Within 2 years after suffering a DVT, 20% to 50% of patients will develop post-phlebitic syndrome. And post-phlebitic syndrome is the main determinant of the quality of life after DVT. It's more common after a first proximal DVT than after a first distal DVT. And you may be familiar with some of the symptoms and signs of post-thrombotic syndrome, symptoms including pain, swelling, cramps, leg heaviness, leg fatigue, itching or paresthesia, and signs including edema, telangiectasias, venous dilatation, varicose veins, redness, cyanosis, and hyperpigmentation. Well, what happens? What's the pathophysiology here? Normally, the leg veins have these very thin, delicate valves. When they're functioning well, they make sure that the blood flows in the proper direction toward the heart and that there's no leakage backward. But when there's damage to the leg veins, which can occur due to thrombosis and to inflammation, these delicate valves get injured, often permanently. And the valves become leaky and allow fluid to pass through them, resulting in edema and pain. Here's an example of progression of chronic venous insufficiency. You could start off with stasis dermatitis, with skin oozing, and this is common in the lateral malleolus. Can progress to chronic edema and advanced pigment changes, and then probably in 1% or so of these patients, you can get these very devastating, actually, venous stasis ulcers, which require going to wound clinics and can take months and months to recover from. Now, in terms of VTE management strategy, I want to spend a little time comparing rivaroxaban against apixaban. And I also want to ask the question, is warfarin dead? We have 4 DOACs. 3 of them work to inhibit activated clotting factor 10, and 1, dabigatran, works as a direct thrombin inhibitor. Dabigatran was the first DOAC to get to market. It had a poor launch. There was failure to educate providers that the drug is metabolized by the kidney and that dose reduction or drug avoidance is warranted in patients who have stage 4 or stage 5 chronic kidney disease. And particularly in Australia and New Zealand, there was initially a wave of hemorrhagic deaths. On the other hand, when used properly, I think, even though there were no head-to-head studies, that the DOACs have probably served well with dabigatran as the most potent DOAC. It certainly has the largest rate of stroke reduction in patients with atrial fibrillation. And dabigatran is the only medication where there are two generic versions that have been FDA approved. Rivaroxaban was second to market. It was the first DOAC approved for once daily dosing. The short half-life is probably responsible for a bit less efficacy than the other DOACs. Now, there are some very bothersome side effects. Rivaroxaban can cause severe migraine headaches. And when we get that page, we have to send our patients for a head CT scan in case they're having a head bleed. Rivaroxaban, for reasons we don't really understand, can also cause severe genitourinary bleeding, which may require cystoscopy or DNCs. But rivaroxaban is a good choice for patients who are going to have adherence challenges with twice daily dosing. Apixaban was the third DOAC to market. It has excellent efficacy and safety, and it's straightforward dosing in terms of maintenance, either 2.5 milligrams or 5 milligrams twice a day. In fact, there are only tablets of 2.5 milligrams or 5 milligrams. With apixaban, we need to help our patients remember to take the evening dose. And one thing they can do is set the alarm on their smartphone for that evening dose. And the manufacturer has remained laser focused on atrial fibrillation and venous thromboembolism rather than trying to develop a bunch of other indications. Apixaban excels against its competitors in prevention and treatment of VTE in oncology patients. Finally, edoxaban, the fourth DOAC to market. There's resistance from insurers and formularies to include edoxaban as a DOAC option. After all, do we really need to have 4 DOACs on each formulary? However, edoxaban is an excellent drug. It's given once daily. There's excellent absorption on a full stomach or empty stomach. It's effective and well tolerated, and it's the only DOAC proven superior to warfarin in preventing recurrent VTE. Edoxaban has also developed a special niche in treating geriatric patients with a tiny dose of 15 milligrams per day rather than the standard dose of 60 milligrams per day. Well, what does that mean in trends of the use of oral anticoagulants for VTE in the United States over the past decade? Most noticeable is this purple line. This is warfarin, and its use has plummeted. Then we have the 2 DOACs that have not done well from a utilization point of view in the United States. They are dabigatran and edoxaban. Rivaroxaban started off doing well, but then its use has begun to fall off, whereas apixaban has had a straightforward, almost exponential increase in use in the United States. Well, what is it about apixaban? There are no randomized trials, but for observational studies, when we look at 15,000 patients, we see that apixaban has a 63% reduction in recurrent VTE compared with rivaroxaban. And apixaban has a 46% reduction in major bleeding compared with rivaroxaban. In the cancer trials looking at acute VTE, DOACs were compared with the low molecular weight heparin, dalteparin. Edoxaban and rivaroxaban both had better efficacy than dalteparin, but they had more GI bleeding than dalteparin. On the other hand, apixaban had the same efficacy and same safety as dalteparin, meaning that patients could take oral medication rather than daily or twice daily self-injections of low molecular weight heparin. Now, warfarin does have multiple problems. I think the most frustrating one is that there can be a high rate of major bleeding, even when the INR is within the target rate of 2.0 to 3.0. For intracranial bleeds that occur on warfarin, 40% of these patients are within the targeted therapeutic range when they suffer their intracranial bleed. There is more major bleeding with warfarin compared with DOACs. Warfarin's inconvenient. There are blood draws to figure out the dosing and dose adjustments. There really are hundreds of drug-drug interactions and drug-food interactions with warfarin, especially with healthy green leafy vegetables, which we all are encouraging our patients to eat. Now, believe it or not, Coumadin has had such poor sales that it is no longer manufactured anywhere in the world. So Coumadin shares the fate of other legacy businesses, TWA, the Christmas tree shops, Filene's, Jordan Marsh, and Oldsmobile. So does this mean warfarin is dead? Well, when we look at antiphospholipid antibody syndrome at the 4 randomized clinical trials, comparing warfarin with DOACs, what we find is that if you use a DOAC, there is an increased risk of arterial thrombotic events, especially stroke. For PE and DVT, there is no change in the odds whether you use DOACs or warfarin. Warfarin has multiple indications. It's important when we want to monitor medication adherence. When we're dealing with frail and obese patients whose dosing is challenging, and frail and obese patients are rarely included in clinical trials, for treatment, particularly of triple positive antiphospholipid antibody syndrome. For patients who fail a DOAC and have recurrent VTE or stroke despite the DOAC, when there's major bleeding despite prescribing a DOAC, and something that's important, I think, particularly in hospitalized patients where one size does not fit all, is that we can titrate the intensity of anticoagulation. If we want high intensity anticoagulation, we can pick an INR range of 3.0 to 4.0. Standard intensity, of course, INRs 2.0 to 3.0. And there are situations where low intensity anticoagulation is warranted, and the INR range can be targeted to 1.5 to 2.0. Now, I want to caution against using DOACs in several situations: thrombotic antiphospholipid antibody syndrome, rheumatic atrial fibrillation, mechanical heart valves, or LVADs. The DOACs just have very poor efficacy under these circumstances, and warfarin should be used. Of course, in pregnancy, the safest anticoagulant appears to be low molecular weight heparin. So finally, I want to give some tricks of the trade in managing the dosing of warfarin. I had the privilege in 1996 of starting an anticoagulation service at Brigham and Women's Hospital. We started in the first month with 80 patients, and now we've increased to 1,500. So don't check the INR more than twice per week. Otherwise, we'll be chasing our tails. And make small, subtle changes in the dosing. Remember to ask about adherence to warfarin. And caution patients that alcohol, NSAIDs, fish oil capsules, and turmeric can really throw off and usually increase the INR. Certainly in New England, we want to humidify the bedroom at night to prevent nosebleeds. And prescribing warfarin to be taken at 8 p.m. is a good idea because it allows us to get the results of the INR during the day and then to contact the patients before that 8 p.m. dosing. When we're having trouble increasing the INR, it's hard to believe, but low dose vitamin K can often help. It's counterintuitive, but it's a trick of the trade. And if the warfarin dose exceeds 12 milligrams, I believe it's best to administer the warfarin twice daily. Okay, I'm going to turn now to the most controversial aspect of PE and DVT management. And this is a great example of clinical equipoise. So the question is classifying a DVT or PE as provoked or unprovoked relevant and important? The American Society of Hematology says yes. The European Society of Cardiology says no. And does evidence support this classification of provoked versus unprovoked to determine the optimal duration of therapy? The American Society of Hematology says yes, and the European Society of Cardiology says no. And there are no good trials to definitively tell us what to do. So I figure I'll just share with you my approach to figuring out the duration of VTE anticoagulation. I ask certain questions prior to setting an end date for anticoagulation. First, is VTE a surrogate for having a high risk of MI, stroke, or diabetes? And I always check the LDL cholesterol, the hemoglobin A1C, and the family history for PE and DVT, as well as MI, stroke, or diabetes. Is there a prior history of PE or DVT? In these patients, I'm inclined to continue the patient on anticoagulation, even if it's a provoked DVT or PE, past this arbitrary date that's used of 3 months or 6 months. Is there laboratory evidence of antiphospholipid antibody syndrome? Well, if these results are triple positive, I'll put these patients on warfarin and continue them without an end date. We used to call that indefinite duration anticoagulation. Is there active cancer, possibly occult? If the answer is yes, stopping anticoagulation is not necessarily the route we want to take. And most hopefully, are there cardiovascular risk factors that we can reverse, and after reversing them, then discontinue anticoagulation? And the answer is yes. And they include CPAP for obstructive sleep apnea, cessation of cigarette smoking, encouragement of switching from a sedentary to an active lifestyle, and treating obesity. Sometimes we have to deal, especially in the hospital, with advanced pulmonary embolism where anticoagulation alone does not suffice. I'll show you an example of a patient who had a intermediate high risk pulmonary embolism manifested by acute right ventricular dilatation, both on the CT scan and on the echo. So the right ventricle is ordinarily has a diameter that's less than that of the left ventricle. So the RV to LV ratio should not ever be more than 0.9. Here it measures 1.6. The same patient underwent an echo, and it's unusual to get exactly the same RV to LV ratio, but in this case we did. The right ventricle diameter being 1.6 times greater than the LV end diastolic diameter. And these patients have a worse prognosis than those who maintain a normal size and normal function right ventricle. Some options for reperfusion are catheter-directed thrombolysis with or without low-dose TPA, ultrasound-facilitated catheter-directed thrombolysis with low-dose TPA, a surgical pulmonary embolectomy with or without ECMO, and systemic thrombolysis. By that I mean administering TPA through a peripheral vein. And when do we tend to initiate reperfusion therapy? Well, certainly when the patient is hemodynamically unstable, if there's severe or persistent right ventricular dysfunction, if there's lack of clinical improvement or there is clinical deterioration, or there's persistent hypoxia. And these are problems we face in the hospitalized patients, very relevant to hospital medicine. Here's a patient who came in with a massive pulmonary embolism. This is a saddle pulmonary embolism in the main pulmonary artery. There's also a huge amount of thrombus in the right main pulmonary artery and the left main pulmonary artery. The same patient, upon admission, had a right ventricular end diastolic diameter greater than the left ventricular end diastolic diameter. This patient went directly to surgery for an open surgical pulmonary embolectomy. And on post-op day number 40, imaging was repeated. Now, you see there's still some pulmonary embolism, but the saddle is gone. It's no longer there. And now the right ventricular end diastolic diameter is slightly less than the left ventricular end diastolic diameter. And let's think about what we have to do in the hospital for adjunctive therapy for patients with massive PE, aside from dealing with anticoagulants and thrombolytic agents. Well, we have to ensure excellent oxygenation. And we should not volume load the fragile right ventricle with more than 500 ml to raise the blood pressure. Consequently, for PE, we need to have a low threshold to begin pressors. And the feeling is that the pressors should be given in this order. Number one, norepinephrine, and if necessary, adding on top of norepinephrine, dobutamine. The FlowTriever is a 20 French device in which it's put in the cath lab, and it can basically trap large amounts of pulmonary embolism and extract them without TPA. This is the ultrasound facilitated catheter-directed thrombolysis. And what you see here are two catheters. There's an outer catheter, and then the inner catheter has little ultrasound emanating from it. It's low powered, but this ultrasound combined with low dose TPA will be able to cause these fibrin strands that here are thick and tightly wound to thin, and the network will loosen. And the ultrasound also causes acoustic streaming so that small doses of TPA can get into the interstices of the thrombus. Systemic thrombolysis decreases the death rate by 35 to 50%, but causes a 2 to 3% rate of intracranial hemorrhage. In 1990, the FDA approved systemic TPA to treat massive pulmonary embolism in a dose of 100 milligrams as a continuous infusion over 2 hours. Now, because of the high intracranial hemorrhage rate, we're not using systemic lysis very much, but consider it if the patient is otherwise young and healthy, and consider it if you cannot mobilize quickly interventional radiology, interventional cardiology, or cardiac surgery. And I will say that in Boston, that can be a situation of a very large snowstorm, or it can be on the fireworks night, 4th of July, when all the roads are blocked. Here you see pre-fibrinolysis, large right main pulmonary artery embolism, and after systemically administered TPA, there's marked clot lysis and reperfusion. And the final chapter for this morning is prevention of PE and the impact of obesity and weight management. Well, as the body mass index increases, the hazard ratio for developing pulmonary embolism increases as well. And when you get to a body mass index of 30 and pass it, you're no longer in the overweight category of 25 to 30, but you're obesity class 1. At that point, the hazard ratio for suffering PE is 2.4. Now, semaglutide is the generic name for 3 drugs with different indications and dosing, but it's the same medication. So Wegovy is FDA approved for weight management and for reduction of MI and stroke in obese patients. It's administered subcutaneously into fat tissue. Ozempic is FDA approved for improving glycemic control, lowering the hemoglobin A1C. It's administered subcutaneously. And Rybelsus, again, is semaglutide, FDA approved for improving glycemic control, and it's the only weight management medication of the new breed that can be administered by mouth. So 3 different trade names for what is the same medication. Medicare is now covering Wegovy for patients at high cardiovascular risk because there was a study called the SELECT trial, which showed that Wegovy had a marked beneficial effect in reducing MI and stroke. So in March this year, the FDA approved Wegovy to reduce the risk of CV events in adults with obesity or overweight. These drugs like semaglutide, GLP-1 receptor agonists, and they have a large range of beneficial effects. And we don't understand the mechanisms very well, but they tend to decrease coagulation, decrease postprandial lipids, of course, decrease hemoglobin A1C, decrease inflammation, decrease body weight, decrease blood pressure. And I'll tell you, we don't understand why, but these receptor agonists also tend to decrease the desire to drink alcohol. And in those who like to go to casinos and gamble, these receptor agonists tend to decrease the urge to go gambling. Going back to the FDA approval of Wegovy for cardiovascular reasons, in this 17,000 patient study, the primary cardiovascular composite endpoint of myocardial infarction and stroke was reduced 20% with semaglutide compared with placebo. Death from cardiovascular causes was reduced by 15% with semaglutide. Heart failure was reduced by 18%, and death from any cause was reduced by 19%. So here are my take-home points. Mortality from MI, stroke, and pulmonary embolism is increasing in the United States. Inflammation, such as psoriasis, will increase the risk of VTE. We're respecting that we have to monitor our patients and follow up for the development of post-PE impairment. It's common and it lowers the quality of life. Apixaban appears to surpass rivaroxaban with respect to efficacy and safety. Warfarin is alive, but it's underutilized. The optimal duration of anticoagulation is controversial. And we have a variety of advanced therapies which are used in the hospital, including systemic thrombolysis, catheter-based therapy with or without TPA, or surgical embolectomy with or without ECMO. And the biggest change we can make in terms of preventing PE and DVT is by emphasizing weight management, combining a healthy, heart-healthy diet with exercise, and I think in many cases with these new, somewhat miraculous medications. I've included a set of references for you, and I thank you very much.
Excellent. Dr. Goldhaber, thank you as always. Some really good updates in there from prior years. We have a number of excellent questions from the participants today from your talk. There are a lot of questions around possible failures of direct oral anticoagulants. And so I think one of our participants summed it up as kind of like, what is your approach to determining if a recurrent VTE in a patient on a DOAC is truly a failure? What are some of the principles you use to decide that?
Well, I think most importantly is the patient taking the DOAC. With the Apixaban, it's sometimes they're only taking the morning dose, for example. So I think that's a big problem. We don't really have the ability to measure DOAC levels in the same way we can measure the INR. We can use DOAC levels, and we have them at Brigham and Women's to decide if someone was taking a dose that was going to be lethal, either for a homicide or suicide, or if there's no DOAC on board when we check the plasma level. So it can be challenging to tell. And what I usually do is I consider switching to dabigatran, but often, and more often than not, I'll switch to warfarin.
Okay, awesome. Thank you. Speaking of warfarin, we have another question. It doesn't seem like our audience wanted to let you go with the vitamin K and the INR trick that you had there, and wondering kind of if you might explain a little bit about how you approach that, using small doses of vitamin K to help with the INR management.
Sure. Well, that's a trick I only have to pull out for 1 out of every 500 patients, just to put it in perspective.
Okay.
But it seems that for reasons we don't really understand, sometimes the warfarin just needs some substrate to work against, and that can make a tremendous difference. I didn't believe it until I tried it.
Okay. Okay, excellent. We also have a few questions about initial anticoagulation treatment for patients with various types of PEs and other VTE, and whether or not they need kind of like parenteral therapy with low molecular weight or unfractionated heparin before a DOAC. And how do you what's your framework for that?
Well, I think for any patient who gets hospitalized, by far the trend in the United States has switched to low molecular weight heparin. Okay. First of all, you get therapeutic levels right away. And we all know that with IV unfractionated heparin, aside from the agony of every 6-hour blood draws, patients can go 2 days without becoming therapeutic. And when it comes to judging the quality of care, we would get minus points for that.
Okay, excellent. Another question for you. A really tricky clinical scenario for a lot of us is managing coagulopathy in patients with kind of stable liver disease and cirrhosis with synthetic dysfunction. Yeah. How does that kind of change the way that you approach? And are there, tricks that you can give kind of in a short period of time about how you approach those patients?
Well, if they have severe liver dysfunction, I don't want to drive blind. I want to know the intensity of anticoagulation. And even though warfarin's metabolized by the liver, I'd rather give 1 milligram of warfarin a day and see an INR of 2 to 3 than guess with, let's say, half dose of Pixaban, 2.5 milligrams twice a day. Okay. And do you supplement? Do you make sure those patients have a good amount of vitamin K before you do that as well? I do not.
You do not. Okay. Very helpful. And then I think our last question for you is, who needs an echo when they have a PE?
Another
from your perspective.
Okay.
Yeah.
So I think now most emergency department training includes 6 months of POCUS. And so the ED staff have become very skilled in doing echoes, and particularly we're looking for the 4-chamber view. We don't really need some of the fancy views that a tech can do. And the 4-chamber view, you put the transducer at the apex. You have to worry about angulating the transducer properly. And what we're looking for primarily is a question of right ventricular dysfunction or right ventricular dilatation. I will say, though, it's humbling because we can get surprised. The patient may really have pericardial tamponade, or the patient may really have a large myocardial infarction. with this marked regional wall motion abnormality that's new. So I think nowadays I would say in American hospitals, almost anyone should get a echo.
Okay, awesome. Dr. Goldhaber, thank you as always. I also want to just share with everybody that was kind of our first taste of some coverage on the GLP-1 medications, and we're kind of coming at them from different angles throughout the course, including today. Thank you, Dr. Goldhaber.
Thank
again.
you. It's a pleasure.
Yeah, thank you so much.